Ready? 3, 2, 1, action.
I'd like to call Dr. Jonathan Cavenaugh to the witness stand.
Please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Please can you tell the court your name, your job title, and where you're currently working?
Okay. My name is Jonathan Cavenaugh. I'm an addiction, child and adolescent, and adult psychiatrist. I am a professor in the Department of Psychiatry at Rutgers Robert Wood Johnson Medical School in New Brunswick, and I work for University Behavioral Health Care, directing an outpatient addiction facility in New Brunswick.
And please can you confirm whether you are a member of the American Psychiatric Association, APA, and how long you've been a psychiatrist for?
I am a member of the American Psychiatric Association. I'm also what's called a Distinguished Life member, which is one of the highest recognitions that they can give to their members. I have been treating patients since 1978, but in the public domain actively since 1985.
And do you recognize this book in my hand as the DSM-4, otherwise known as the Psychiatrist's Bible?
Yes, I do. I guess you could call it that. The DSM-4 stands for the Diagnostic and Statistical Manual of Mental Disorders, the fourth revision. It's a description of what we use to make diagnoses in psychiatry and mental health.
And now as I hand you DSM-4, please can you read on page 685, what is code, V code 6289?
V6289, religious or spiritual problem. This category can be used when the focus of clinical attention is a religious or spiritual problem. Examples include distressing experiences that involve loss or questioning of faith, problems associated with conversion to a new faith, or questioning of spiritual values that may not necessarily be related to an organized church or religious institution.
And in relation to that V code, to what extent is it being applied in psychiatric practice, would you say?
A V code is not a diagnosis, which is what we primarily use. A V code is a condition that would need clinical attention, but it often is rarely used. It does not lead to any kind of reimbursement, and we frequently, I don't know if I've actually seen it used in my career.
Interesting. So we understand you have written about a specific approach to integrating spirituality into psychiatric care. Would you explain to the court your experience in this field?
My work in addiction, any of you that are familiar with the 12 steps, Alcoholics Anonymous, it's a spiritual approach to recovery. And as we look at the deepest part of who we are as persons, we would refer to it as our heart and our soul. What we recognize is that there is a spiritual part of us. And it is often out of awareness, but it is often what drives who we are, what makes our direction in life, what makes our purpose, what makes our meaning. And we've identified a way to understand how this spiritual experience is organized psychologically, and we've developed methods that can actually speak to it, address it, and promote what we refer to as spiritual awakening. Awakening a person to that part of them, which is where well-being, where happiness is, where direction and purpose is. And when we do that, there seems to be a definite impact on addiction and recovery as well as trauma.
And so how would you relate this to Anna Biltmore's case?
Anna Biltmore had a spiritual experience. This can be normal, and it often is confusing to the person that has it because our culture, our society just doesn't recognize. In fact, our medical and psychiatric profession almost ignores it. And in this case, she was misdiagnosed with a mental illness, was placed on medications that could have harmful effects, and all of this could have been avoided. Anna Biltmore did not have a bipolar disorder. She had a spiritual experience that got out of control. She was suffering from a brief psychotic episode that probably would have resolved on its own without medications, did not indicate any evidence of any kind of mental disorder. And sometimes these spiritual experiences, because they're not understood, progress in intensity to what we call a spiritual emergency. And this is the part that should be recognized by psychiatrists, by mental health workers, hopefully to even avoid hospitalization, avoid medications, avoid a diagnosis, because especially in Anna Biltmore's case, the diagnosis and the treatment was extremely stigmatized.
Thank you, Dr. Cavenaugh. So please can you tell the court what would have been the treatment plan for dealing with a spiritually transformative experience and the likely number of days that someone presenting with Anna's symptoms and behaviour would have been expected to stay in hospital for?
Had this been recognized at the beginning that this was a spiritual experience, a spiritual emergency, and she was not in danger of herself or endangering others, alternative treatments and not even hospitalization could have been recommended. There would have been no hospitalization, no days at that point.
So no hospitalisation and no days at all, if she'd been correctly diagnosed with a spiritually transformative experience?
Yes, if it had been recognized.
So, just to confirm, are you saying that there would have been a zero bill for Anna had she been correctly diagnosed with a spiritually transformative experience?
Yes, I guess so. She would not have been hospitalized.
So I'm now... Cut. We're supposed to have your